I'm Dr. Deok. I'm working for Asan Medical Center Radiology. My presentation topic today is to share my early experience of using FIL in neurovascular field. As you well know, there are several kinds of liquid embolic materials in the market, such as glue, Onyx and screed, and FIL. This table is a summary table comparing market available liquid embolic materials by microvention company. As you can see here, they compared the viscosity of the available liquid embolic materials, non-adhesive liquid embolic materials. Viscosity is a matter of issue. Onyx, they have 18 and 34 and 500. And in the earlier experience of Onyx here in Korea, we were told that there is two different kind of low viscosity and high viscosity Onyx. I didn't see much difference between the 18 and 34. So far, I'm solely using Onyx 18, which is 6% of the ethylene vinyl alcohol. And FIL 25 is the main armamentarium I'm using with FIL technology. Recently, they introduced the low viscosity FIL, which has 12 centistoke viscosity. By presenting my Onyx experience first and compare those experience with the current FIL experience, make you understanding the difference better. I'm mostly using Onyx in brain AVM and Dural AVF. So start with the brain AVM. Basically, the treatment of brain AVM is to resect or occlude this abnormal nidus, either by surgical resection or embolization or with a gamma knife. There could be several rules of embolization in the brain AVM treatment, balancing the risk and benefit of our procedure. We can do curative embolization or adjunctive embolization together with the gamma knife radiosurgery or surgical resection. Recently, more and more role was found with the targeted embolization. So start with the curative embolization. This report was reported quite long ago by Anton Valavanis, who just retired recently from Zurich. He reported that he could completely obliterate the brain AVM nearly 40% of his cases with a relatively low morbidity and mortality, 40%. Do you think you can achieve this number? Actually, it happens quite rarely in real clinical situation. Then, Onyx will increase the curative embolization success rate. In the real world, as you can see in this trial report, they reported a complete occlusion rate of 23.5%. The morbidity and the mortality rate is quite high. It is higher than glue report. It means brain AVM itself is very hard to treat ghost-like lesion, especially only with the embolizations. And recently, more and more European interventionists are doing transvenous approaches, and they report better curable embolization result with this approach. I have no experience with this. 45-year-old man presented with seizure. He had well-delineated cortical AVM like this in the right parietal lobe. This is the angiography, and the gamma knife was done. However, after 3 years of the gamma knife radiosurgery, he presented with a sudden headache and showed marginal acute hemorrhage. So the AVM was ruptured. Just the upper anterior part of the nidus is gone, and the rest of the residual lesion is still notable. So they planned to resect this ruptured brain AVM. However, before the surgery, the surgeon wanted me to do some adjunctive embolization. I did Onyx embolization like this. And then, as you can see here, the shunt is gone and the flow has decreased significantly, and the surgeon easily resected out. Onyx, it's copolymer of ethylene vinyl alcohol. DMSO is used as a solvent, and the tantalum powder is for radioplasty, and by weight volume, it is 34%, and the volume actually is about 10 or 12% of total amount, the total volume. Onyx has some advantages because of its lack of adhesiveness, and it is not polymerization, it's a precipitation of the polymer as the DMSO evaporates. And they say lava-like flow can happen within the precipitated column. And for stable antigrade penetration of the embolic material, they say plug formation at the tip of the microcaster is a mandatory technical step. The control of the direction of the Onyx lava flow can be achieved pausing the injection, very short duration. Then you can see different direction or different portion is filling through the Onyx cast. Then does that mean Onyx has no problem? No. During adaptation period, I thought every problem was my lack of experience, but with accumulation of my experience with Onyx, I found there's some problem. The patient presented with a seizure, 41-year-old male, had a rather big size cortical AVM at the right frontal fold, and we decided to treat the lesion by gamma knife. Before gamma knife, they asked me to do the pre-gamma knife adjunctive embolization. So I went in and then inject the Onyx. And the final result of my Onyx embolization was like this. And then they did a gamma knife for this. However, during the embolization, I experienced some problem. In the initial phase, the Onyx lava flows smoothly. However, when the lava started to flow backward, it is time to make a plug. So I decided to make a short plug from here or to here in this segment, and then inject slowly. That is not that easy, and repeatedly doing like that, and then it started to flow forward like this. Do you see? Very high density here. So during the plug formation period, even though that injecting Onyx is very hard to see when I inject a very small amount, the following Onyx column is very dense within the microcaster. Why this problem happened? That is because of the sedimentation of the Onyx within the injecting syringe and injecting microcaster lumen. So that's why we continuously shake the Onyx before injection for 20 minutes, and then during injection, we continuously tumble the injecting syringe. So with this observation, I changed my injection style. So first of all, we have to shake the bottle sufficiently, as the IFU said. And secondly, continuous tumbling of the injection syringe during injection and the waiting time. The most important thing, I think, is that pushing the plunge briskly, not softly, to minimize any sedimentation of the tantalum powder. When you have decreased radial density during injection, it means increase the polymer volume, decrease the tantalum powder. It means increase the viscosity. Stop injection when the Onyx column feels an unwanted part, but don't wait too long. Just the brief stop is enough. If it goes the same direction again, just stop shortly again and repeat until it changes the direction. That I think is important to minimize unwanted sedimentation of the tantalum powder. And the other problems with the Onyx, I think, is angiotoxicity of DMSO, I think, is another problem. So that's why they limit total injection volume. And it's painful. So general anesthesia is required, especially for the embolization of the dural region. Dura is painful. So we already reported an interesting case of trigeminal cardiac reflex with the patient with a cavernous sinus lesion. And of course, the most annoying problem is with the tantalum powder. Too dense radiopacity. It generates a lot of problem. Number one, imaging problem. Number two, when you have the dense onyx cast already, then navigation, the adjacent vessel becomes quite difficult because of the non-visibility of the microcast wire. And you have to remember that when the onyx cast is within the radiography fluoroscopic field, the AED of the angio machine, the fluoroscopic machine, will adjust to high radiation. So it increases total radiation dose. That should be a radiology concern. So that's why Phil gets interest, because it has no content of the tantalum powder, because it uses iodine for the radiopacity. And the polymer is a little different, but I don't think the polymer is not that big difference, but there's some trivial, minor difference. I will go with further. Characteristic. So as you know, Phil is copolymer of PLGA and the HEMA. And it does not have any adhesiveness. It shows the occlusion embolic property by precipitation of the polymer when the DMSO is evaporate. And the radio opacity is from the iodine, which is a triiodophenol. Why they use this? I think it's because of the viscosity. This can decrease the viscosity of the polymer, or not increase, I mean. That's why Onyx did not use iodine contrast. They have no choice but to choose the tantalum powder. So anyway, Phil has different polymer with the same solvent, which is DMSO. And for the radiopacity, they use iodine. And the iodine is mixed within the polymer. It never sediment down. It never disappear from the imaging. The iodine will be there permanently. So this is a video clip recorded during second stage embolization with Phil. So you can see subtle radiodensity of the Phil. However, it is perceivable with the current fluoroscopic quality. No problem in the observation, as you can see here. Yes, Phil looks like a perfect material. It has theoretical advantages over glue, which is easy to control, and over Onyx, because it does not require any shaking or tumbling. And of course, because of the iodine, it has less radio opacity, not metal, and no MR artifact theoretically. And the radio density is, of course, homogeneous. So the most problem I have with the Onyx, perfect. However, with my early experience, I have seen several problems compared with the Onyx. Number one, insufficient radio opacity. When the field was injecting smoothly, radio opacity is not a problem in the current fluoroscopy, but it could be a problem in the initial phase of the injection. The DMSO comes first, and then diluted field is following, and the undiluted field is coming. So that transition, I think, is almost non-visible. So arrival of the first column of the field on first is very difficult to be perceived. especially when you are using very low profile microcasters. So it needs some experience. And number two, brittleness of the material. I think it is prone to pass by a shunt compared to Onyx. And that's why for venous approach, the European interventionists do not choose field for their purpose. Why I feel like that? As maybe you can recognize the difference with this picture. This is the field, and this is the Onyx. To me, it is like this. Onyx is a little bit diluted dough, require more flour. It looks thin. And fill, I think, is something like incomplete dough for the bakery. Require more water. It's too thick. It's brittle like this. So with this problem, it has some limitation of penetrating very fine vessel. That's the subtle difference between these two polymer-based liquid embolic material. So I will show you the case. 7-year-old boy presented with a ruptured small AVM like this. They did a gamma knife. And after 3 years, the gamma knife result still shows very tiny residual here, like this. So we decided to go in and embolize the lesion. And the nidus, I think, is like this. This is the vein, so the nidus. We did embolization, this first injection, bidirectional filling of the fill, a little bit of initial regurgitation here. After this, it is very difficult to see the fill because too much injection may be disastrous. I did the injection very carefully, like this. Very hard to see. It's refluxing. So eventually I did like this. However, the end result is like that. Significant reflux here. So anyway, it's a trivial. The reflex is trivial. It's a short segment. So there's no problem at all compared to this. And it was well treated like this. However, the visibility could be an issue, especially when we embolize very small lesion. And next case, 29-year-old male with a left superior quadrant tanopsia with this cortical, occipital cortical AVM, like this. And we decided to do combined treatment. This is 3D angiography finding, and we went in and see the fistula like this, and then begin the injection here. Injection, reflux, antegrade. And this is the point where the microcaster is, here. And this one. The problem is that, see, initial injection, further injection, and then this aneurysmal dilated lesion started to enlarge. So actually the caster is very well made here. The detached zone is here. So we could further inject more, but further injection only dilated this aneurysmal lesion. I don't know, Onyx behaves differently in this particular case or not, but I have no choice but to stop the injection here because of this unwanted bulging problem. This is the end result. And then I select another feeder and did a further injection like this. And this is the final result and sent for the gamma knife for the residual lesion. How about this case? 59-year-old man, left side weakness due to this kind of secondary change of the draining vein, severe edema of this degenerated brain AVM. The angiography was like this. The associated aneurysm was embolized in other hospital many years ago, and this is migrated the tiny coil here. So basically the AVM flow is not that fast. So I thought that I could embolize in curative purpose. This is the dilated draining vein, aneurysm formation, and the mural thrombus here. So we went in the MCA using the intermediate caster like this, and then put the microcaster and started to embolize with the fill. This is the one by one, gradually, first embolization, second embolization, and third embolization. Those embolization was done in 2 or 3 months intervals. And then this is the final result, curative embolization. And then this is the final CT scan. You can recognize the collapsing venous ectatic lesion like this. And see the radial density of the field mass. It wasn't successful in every case. This is a dural AVF case, 55-year-old man, chronic headache and posterior neck pain, presented with this unusual vascular lesion here. And it turned out dural PR type of fistula in the cranial vault in the left side. So we went in there. It was difficult, and we get in, and then started to inject the fill like this. This actually is a proctor case of my first embolization with the fill. I think it was not that problematic, well done procedure. And this is the final result. The fistula is gone, and this is the fill cast. However, on follow, patient did not show any problem. On 6 months imaging follow, ASL image showed the shunt. So we did the angiogram again and showed the recurrence here. So we went back in, and this time the retreatment was done with Onyx. Density is different, right? The fill and Onyx, and it's gone. So actually, we have 2 initial proctor case with a very small dural PR type of fistula, dural fistula. Unfortunately, those 2 cases were recurred and retreated with the fill. But there must be some limitation of penetration of the fill in the very small lesion. This slide is my conclusion slide. By summarizing the fill characteristic, I'd like to finish my talk. Fill is much easier in handling and injection compared to Onyx. However, the radioplasty is the advantage of the fill, but it could be a disadvantage, especially when you are injecting very low profile microcaster. You should be careful in recognizing the initial column. So permanent radioplasty is not a big issue in our imaging tool so far. So with this, I'd like to finish my talk. Thank you.